Now we're going to expand our discussion and move to stem cells. And Dr. Brian Cole from Rush University is going to talk to us a little bit about his research and experience with stem cells for articular cartilage. Brian?
Good evening. So I will, Scott, that was an outstanding overview, and you really covered all the things we kind of need to know, and it'll be kind of fun to answer some of the questions at the end. And I'll stick basically with articular cartilage in the setting of osteoarthritis and focal defects. My disclosures are on the U.S. disclosure program, the website. The rationale for biologics, whether it's the PRP that Scott just discussed or MSCs that we'll discuss now, we're generally using two scenarios. One is either alone, say in an office setting or an outpatient surgical setting, or as an adjunct to surgery. And the premise is that we provide anabolic or anti-catabolic molecules that basically can modify an arthritic process, and maybe even promote regenerative cartilage tissue in this case, or some of the other tissues such as synovium, MSCs, and some kind of bone can't be modified. I think it's best to think about, in the setting of knee osteoarthritis, the knee as an organ. So it's not just the cartilage. In fact, in many scenarios, the cartilage is probably the least important contributor to why patients have symptoms. And we need to start thinking more globally about the synovium, potentially the presence and activity of host MSCs, and certainly the subchondral bone. So specific to stem cells, is it a dream or is it reality? Stem cells can work in two major paradigms. The one that we most commonly adopt is this concept of medicinal signaling cells. And it's really Arnie Kaplan who deserves the credit for coining this terminology. And the basic three variables are that MSCs can recruit other stem cells, they secrete bioactive factors. In that category, they're anti-scarring and anti-apoptotic, which might be very important in the setting of osteoarthritis. And they modulate the local environment, including providing very strong anti-inflammatory factors, and actually can affect the immune system. So the traditional paradigm has always been that, well, stem cells are interesting because we can drive them from their premature or immature state to terminal tissue formation, and that's the benefit of stem cells, and that's what the public perceives. But the reality is all of this conversation is largely related to the effects of their bioactive factors and how they modulate the organ in almost a paracrine type effect. The basic strategies as far as where we get these cells are either from bone marrow, adipose tissue, synovium, or peripheral blood. They can be either concentrated or expanded, and they can be provided as an intra-articular injection or at the time of surgery as an adjunct to other procedures. Now, the regulation of stem cells currently is essentially as a biologic and a device. There are two divisions at the FDA that regulate most of what you and I do daily, and that's either the CDRH, which is for devices, or CBRE or CBER, which is biologics. But truth be told, the last couple of times that I've been to the FDA for some of these issues, it's really both of these agencies, often dominated now by CDRH, that governs virtually everything that we're currently doing. So it's a hybrid approach. And the one pathway that is perhaps most complex is the 351 pathway. And essentially, these are agents which are manipulated. I'll go into greater detail. They may have some chemical alteration. It's a lot like a drug. And from the manufacturer's point of view, they certainly have developed the process and so forth. Then they have to undergo preclinical testing, much of the kind of things that Scott just talked about. Then they have to undergo a very rigorous clinical pathway. And in the end, it's typically $30 to $50 million over a 6 to 8 year process. So you can imagine that it requires a significant market before one starts considering which things we're really going to go through this drug combination pathway with the device, given the time commitment and the relative size of the market. The kinds of things that fall into this 351 classified pathway are cultured bone marrow stem cells, for example, and there's ample evidence both preclinically and clinically that cultured bone marrow MSCs may have some positive beneficial effects when applied in osteoarthritis and in the treatment of focal cartilage defects. The problem is both of these studies are level 4 studies, but there is some objective evidence. Interesting, for example, looking at MRI association with osteotomy when MSCs are applied at the time of treatment, for example, as an adjunct to marrow stimulation. The problem is the lack of a control group, and what we're often generating is not really cartilage-like tissue. And I would submit to you that the reason these patients get symptom relief has very little to do with the quality of the tissue that is being formed. This is a video showing a phase 1-2 study that Andreas Gamal and I were involved with, and it was basically a very limited number of patients. The study is now closed. This is a Korean technology that basically takes adult MSCs through placental cord blood, uses a form of a neurostimulation technique. And it's interesting, the data from Korea, which I've recently reviewed and has been presented at the ICRS, is largely arthritic type patients. And these are patients that often have some bipolar disease. They have larger arthritic type lesions. They were treated with inch holes, and then a combination of cultured MSCs from placental cord blood, which extends the defect, led to significant improvements compared to neurostimulation. Obviously, the Korean data can't be used to get to the FDA here, so this was an initial study looking at a population of patients compared to neurostimulation alone versus HA with placental cord blood. None of the results I can share, but the results from Korea are beginning to get published. Peripheral blood MSCs is an interesting one because obviously peripheral blood is readily available. So these are hematopoietic stem cells. They can be upregulated by the so-called SAW technique. It's simple venipuncture and using a chemotherapeutic agent to do so. The challenge is when you're talking about a disease, say, such as osteoarthritis, and then weighing the risks and benefits of using a chemotherapeutic agent, one has to start asking the tough question, is this the best way to go? So you'll see a lot more of this in the near future as they go through the FDA regulatory process. To date, there's only one level 1 MSC study in the area of osteoarthritis in the United States. This was a study that was initially interested in looking at the primary aim of what happens to meniscal volume in the setting of a meniscectomy. And a couple of things were identified. One was that, like many things in orthopedics, we see a biphasic response. For example, that low dose or high dose may be better. And in this case, they found the low dose of MSCs, these are allogeneic marrow MSCs, did better than high dose MSCs. And they actually saw some increased meniscal volume at the time of MRI evaluation. We haven't heard much from this company. I believe it was initially Osiris. It's unclear where they're going at this point. We're not hearing a whole lot. But it's interesting that this, to my knowledge, is the only real level 1 MSC study to date in the United States in the area of osteoarthritis. So I described the 351 pathway to you, and that's a very rigorous pathway that you should think about just like any drug that has to get to market. Now, there's another pathway, which is the 361 pathway. So this is the stuff that's available to you, essentially, in your operating room today. And it's essentially roughly what PRP is regulated under, but this is where bone marrow aspirin concentrate is regulated, and some of the other things like amniotic tissue that you're currently seeing. And there's essentially 4 basic criteria. It has to be minimally manipulated. It has to be used for homologous use, and that's an area that's very confusing, and I'll make a comment shortly on that. It can't be combined with any other agent. It has to have no systemic effect, and it has to be used as a point of service. In other words, you can't do something in the operating room, leave the operating room, go to a laboratory, and bring it back. So you can see it's a fairly narrow definition of what we would otherwise say is minimally manipulated tissue. The problem is that this has opened up the pathway for a very unregulated industry and has prompted the FDA to get increasingly involved. In fact, it was recently cited in an editorial in the New England Journal of Medicine that the United States now has the world's highest density of online stem cell tourism in the world. So the FDA, as I've alluded to, is taking a more rigid stance in this area. The concept of minimal manipulation, for example, it cannot alter the relevant biologic characteristics of the cell, so that's a very important point. Homologous use. It fails to clarify really if the tissue should perform all of the prior functions or only some of them. One might ask, look, if fatty tissue taken from, say, the stromal vascular fraction of fat from, say, a small area of liposuction, is that homologous use? Does that actually perform all or even some of the functions that it naturally would by injecting it into an arthritic knee? Same thing for amniotic tissue. So the FDA will probably hit this point harder than others, and it's unclear where it's going at this point, but there's a suggestion that some of those tissues that I just mentioned might be hit with the proposition that they have to start being thought of as 351 products rather than 361 products. And then finally, what I alluded to is this same surgical procedure. For example, liposuction. If you want to do liposuction to get the stromal vascular fraction of fat and some of those MSCs to promote anti-inflammatory properties, and you isolate them, say you do it in a mechanical way, which is out there, and then you inject them, you have to do it in the same surgical procedure. In other words, leaving the operating room, processing it outside the OR, bringing it to a lab across the street, coming back the next day, isn't something that would be allowed under the current algorithm. So fatty tissue, the use of fat has been looked at and is probably a viable treatment strategy as far as the role of fat in the setting of osteoarthritis. There are a number of preclinical and clinical trials that have used fat, and there are systems now on the market that can currently be used in the operating room setting where a small amount of fat is taken. They're digested essentially in a mechanical fashion and then injected. It's really interesting if you look at the labeling on how these can be used. You're not going to see much in the way of labeling. It's always used to say for healing and regeneration of injured or damaged tissue. What you shouldn't see is that it should be applied in an osteoarthritic milieu. They don't have any specific labeling for that purpose, but rather virtually everything you see in the area of fat, for example, in the area of amniotic tissue, is for healing and regenerating injured tissue or repairing damaged tissues. And that's it. So suffice it to say, one might assume that about 95+% of the use of these things is actually off-label. Another you'll see here is the harvest system, which is an adipose concentration system. So you'll see a number of these on the market that are basically centrifuging fat tissue and then re-injecting it into an osteoarthritic joint. Bone marrow aspirate concentrate is what you will hear about most. And essentially, you can take about 50 to 60 cc's of bone marrow aspirate. It concentrates into about 14 times. You're not talking about huge numbers of MSCs there. These are MSCs that probably live as pericytes on the trabecular bone. And it is a technique-sensitive procedure. It offers cells that are phenotypically stable. And in some respects, it can be a lot like PRP made from bone marrow, but with an increased concentration of MSCs with a very small volume. It may also have an increase in white blood cells and less fibrinogen, depending on the system that's being looked at. So why would you concentrate bone marrow? Well, the short answer is to get a large number or even a moderate number of MSCs, you need an awful lot of bone marrow aspirate. So we concentrate it so that it's consistent with a surgical procedure or an office-based procedure. We're not going to inject 60 cc's, but rather it makes sense if you can inject 3 or 4 cc's and get the same number of bone marrow MSCs. The other reason is that basically what happens is there's more biologic activity going on. This is some work that was done by Gus Mazaka's lab looking at colony-forming units, which basically looked at bone marrow aspirate compared to bone marrow concentrate, and basically is an index of activity, if you will. It doesn't show end-stage activity, it doesn't show what's being produced, but it shows cellular activity, showing that bone marrow concentrate does better with CFU evaluation, that's colony-forming unit evaluation, than just bone marrow aspirate. There's a number of bone marrow aspirate concentration systems on the market, and you'll have to do your own diligence as far as what works best for you. Where should we go? Well, many of us, as orthopedic surgeons anyway, are not particularly comfortable going to the iliac crest, certainly the posterior crest. Maybe the spine surgeon will feel better in this area. So we've looked at various locations, such as the proximal tibia. It'd be great if we can get bone marrow aspirate concentration in the proximal tibia, because we're right there when we're doing a knee procedure. Similarly, the proximal humerus when we're doing a rotator cuff repair, as well as the iliac crest for all other procedures, you've got to kind of feel comfortable. At this point, when we look at all the data that's out there, as far as where we should go, we sort of looked at this, as have others, this article published by Marks, but this grid we put together, just looking at what's out there in the literature, suffice to say that it seems that the greatest yield still seems to come from the posterior and iliac crest, but you can't get to concentrate from the proximal humerus and the tibia. So then, from an intuitive sense, does bone marrow concentrate make sense in osteoarthritis? Many of you have heard of the orthokine procedure, the procedure that's done in Germany. And it's basically where an aliquot of blood is taken and divided up and essentially incubated with glass beads at a higher temperature. And there's a series of 3 to 5 injections that are provided. And the premise was that IL-1 receptor antagonist, which can mediate inflammation present in osteoarthritis, can be increased. And this is some recent work that's not yet published, but came out of Lisa Fortier's lab. And basically it was very interesting. It looked at the amount of IL-1 receptor antagonist in bone marrow aspirate concentrate and showed that it had a pretty decent amount of this receptor antagonist. So from an intuitive perspective, it may make sense that it can modify the arthritic milieu by this mechanism, as well as the provision of other anti-inflammatory factors. Now, used in surgery, bone marrow aspirate concentrate has shown some benefit with focal cartilage defects. But unfortunately, it's a lot like the data that I showed you before with cultured bone marrow and focal defects. These are typically level 4 case series They may look at histology, but without a control group and without large enough numbers, don't really have a good take-home other than to say that the biology looks good and it may promote a favorable response as an adjunct to treatment for focal cartilage defects, for example, combining with marrow stimulation. Now, what about bone marrow aspirate concentrate with osteoarthritis? Rather than go through all the literature, I'll just summarize based upon 2 slides and then a third recent study. This is the first meta-analysis that I was able to come across, and it basically looked at what was really present in the literature up until recently. These are heterogeneous studies. They were often in the pain management literature. Many of these patients would be treated with prolotherapy and then come back a week later and get a combination of something like bone marrow concentrate, adipose tissue, and PRP. So it's almost impossible to separate out and make a reasonable conclusion of the role of MSCs from the first generation literature. More recently, this was published as a 2-series back-to-back reviews in American Journal of Sports Medicine. Rob Leprade was the contact author. And basically, it's a systematic review for both focal cartilage defects and osteoarthritis. And they identified 11 studies in the literature. 5 were prospective, 1 was retrospective, and 5 were case series and reports. There were 3 studies for osteoarthritis and 8 studies for focal cartilage defects. Basically, the same conclusion. There's a paucity of high-quality studies. Bone marrow aspirate concentrate appears to be safe, and at this point, judicious use is recommended until we have better evidence. This is the final study, basically, which I thought was really interesting, that looked at a placebo control. I would love to do this study because really we don't think we have systemic effects. If we could identify this population of equally symptomatic who have bilateral knee osteoarthritis and treat them randomly left versus right versus left, like this study did, and they basically used bone marrow aspirate concentrate with platelet poor plasma, and then they compared it to saline. And they showed dramatic relief in both groups, and no difference between them. And I think I just want to point out to you that other than the Pat Smith study, which was recently published with 15 patients in each group, virtually every study in the literature that's looked at osteoarthritis using saline as a control has shown about a 35 to 40% response rate with saline. And the magnitude of change was about the same as the experimental group. So needless to say, there's a lot of companies that are having a really difficult time getting new products to market because saline actually does a very good job. Obviously, we worry about the placebo effect in this environment. The treatment effect is enormous in an injection study, but there actually might be some therapeutic benefit to saline when you go back and look in the literature. So at this point, we have to think long and hard about how we design our studies because of this issue. Now, I mentioned that there's a whole litany of other 361 sort of below-the-bar products. Amniotic tissue is one of them. In vitro, they have been shown to inhibit lymphocyte proliferation and production of anti-inflammatory and chondrogenic cytokines, and they might even enhance chondrogenic differentiation in a repair model. We had a review article in 2015, and I can tell you that this article should probably be redone because at the time there were about 15 companies. The only basic science in osteoarthritis was an animal, a very small rodent model. And at this time, there is more research, but there's many, many more companies available that provide lyophilized, dehydrated cryoppreserved sheets, cryoppreserved liquids, and so forth, with and without allegedly viable cells, decellularized, and so forth. At this point, it's extraordinarily confusing that lacks generalized reimbursement that we're struggling to make heads or tails of. So in conclusion, leukocyte-poor PRP, like Scott talked about, for OA is becoming a dominant treatment strategy, but we're still learning as we go. We know little about the dosing. The FDA regulatory process of MSCs is a moving target, and we will see increasing oversight and business risk aversion for these products as these therapeutic options expand. And bone marrow aspirate concentrate for osteoarthritis, the basic science may actually support it, but the clinical evidence is severely lacking at this time for ubiquitous clinical uptake. Finally, just make a quick pitch. There's a sports medicine course that will be on February 7th, 2017 through the 12th. It's an AOSM course if you're interested. That will cover a lot of these as well as other emerging trends in sports medicine. I really appreciate your attention. Thank you very much.